Hello everyone, now we're going to continue with our discussions of endocrinology. Okay, so when you see a 44-year-old man came in because of fatigue, loss of libido, erectile dysfunction, and you do lab work, you see testosterone is slightly low and creatine is elevated. Okay, so there is a kidney disease. Okay, creatine is like 4.4, and then they ask, okay, why low libido in this patient? And then the answer is CKD. Of course, CKD can cause hypogonadism, can cause a lot of things. Okay, so now you could ask yourself, why is that? Because CKD can cause hyperprolactinemia. Okay, what could cause hyperprolactinemia other than CKD? Pregnancy, breastfeeding, and stress. This is physiological. There are pathological causes for hyperprolactinemia. Is that pituitary adenoma, malignancy, sarcoidosis, antipsychotic or metoclopramide, hypothyroidism, chest wall injury, if you have burn or herpes zoster, kidney disease, and generalized tonic-clonic or focal seizure can cause hyperprolactinemia. All right. Now, if you have a patient that you suspect acromegaly, okay, what would you do if you suspect acromegaly on this patient? How do you suspect acromegaly? Usually the way it presents, 41-year-old, have tingling sensation. What is that? Tingling sensation in both arms. This means bilateral carpal tunnel syndrome. You see skin tags. Okay. So what is best next step if you suspect acromegaly? The insulin-like growth factor. IGF. So when you suspect IGF-1 is called, okay? So when you suspect acromegaly, you want to check the IGF level. If it's normal, this rules out acromegaly. If it's elevated, then you do oral glucose suppression test. If there is adequate growth hormone suppression, okay, this rules out acromegaly. If there is inadequate growth hormone suppression, okay, you after glucose suppression test, then you do MRI of the brain. If there's pituitary mass, you do surgical versus pituitary management. If there's normal pituitary, you can evaluate for extra pituitary causes of acromegaly. Like, is there ectopic growth hormone, GnRH secreting tumors? Like, are people taking growth hormone, you know? So this is the premise of this question. Now, you see 27-year-old having hypertension, hypokalemia, muscle aches, resistant hypertension. So you see CT normal adrenal gland and high aldosterone, like 35, okay? Renin is low, okay? So high aldosterone to renin ratio. So you expect Cohen syndrome. So, but you don't know which gland is causing the issue. Is it right or left? So what do? You do adrenal venous sampling, okay? So whenever you see somebody with hypertension and hypokalemia, you check aldosterone to renin ratio. If it's normal, you evaluate for other causes. If it's elevated, then you do adrenal suppression test. Okay, if it's negative, you evaluate for other causes. But what if it's positive adrenal suppression test? You do adrenal imaging. Okay, if there is normal CT or age more than 40 or an abnormal CT, then you do abnormal adrenal venous sampling. If there is unilateral, then you do surgery. If there's bilateral, you do medical therapy. But what if there is discrete unilateral adenoma on imaging or age less than 40? Just do surgery right away, okay? If it's normal, then you gotta do the other route. The venous sampling, which means. Okay. And also this brings us to the discussion of hypertension and hypokalemia, which causes that, okay? There are a few things that causes that, hypertension and hypokalemia. If you have both aldosterone and renin elevated, then this could be secondary hyperaldosteronism, like renovascular hypertension, malignant hypertension, renin secreting tumor, or diuretic abuse. If the renin is low and aldosterone is high, could be aldosterone secreting tumor or bilateral adrenal hyperplasia. What if they're both low? This could be non-aldosterone causes like congenital adrenal hyperplasia, deoxycorticosterone producing adrenal tumor that can mimic the effect of aldosterone, but it's not aldosterone. Cushing syndrome, exogenous mineralocorticoid, can cause similar symptoms. Okay. Now you have a 26-year-old guy, okay? So he work out in the gym, taking gyms, okay? At the gym, muscular, and have small testes, okay? So what do you suspect? Muscular guy with small testes, this you suspect there is like the patient taking testosterone, okay? So what do you expect? Other labs, okay? Well, that's next step. But next you're gonna see low LH. You check LH FSH, it's gonna be low. And that confirm exogenous use, anabolic steroid abuse, okay? So what are the side effects of anabolic drug abuse? Okay? So people take it to have a better muscle mass, which it does cause that. But it has a lot of side effects, like especially on the reproductive organ. It causes low testosterone, low FSH, low LH, testicular atrophy, spermatogenesis, because the body says, okay, there is testosterone, so why do I need to produce the testosterone? It's the body designed to preserve itself. So low testosterone, low LH, FSH, decreased spermatogenesis, low. You have normal libido and erectile function during use. When you use it, you have erectile function is fine. But once you stop using it, you have impotence and low libido. You won't be able to function if you stop using it. Okay. There are endocrine causes like high LDL, low HDL cholesterol, cause erythrocytosis, and psychological symptoms cause affective symptoms, aggression, cause acne, gynecomastia as well. Okay, it's interesting. Now you have another guy, 51, have a motor vehicle accident, taking opioid. Okay, so after that you should start taking a lot of opioid. Okay, after taking opioid, what happened? Had loss of libido. Testosterone is like 180. Okay, so low testosterone, FSH and LH are low as well. FSH like 3, LH like 1. This is not good, right? TSH and T4 is fine. So what could be causing that? Why is that? Okay, this is due to chronic opioid use can cause that. Okay, now another case, you see 44-year-old man, loss of libido, fatigue, okay, low testosterone, low FSH LH, FSH like 5, normal is 5 to 15, and low LH like 4. Okay, normal is 3 to 15 as well. So they're both low. Okay, testosterone is low, like 175. So what is going on in here? Okay, somebody fatigue, hypogonadotrophic hypogonadism. Why is that? Like, what are other causes? Opioid can cause, but other causes, chemochromatosis, okay, can cause that as well. Can cause hypogonadotropic hypogonadism. What other things can cause? Can cause skin pigmentation and diabetes. So it's called Brown's diabetes. Arthralgia, high chondrocalcinosis, elevated hepatic enzyme, hepatomegaly early, cirrhosis later, increased risk for hepatocellular carcinoma, cause diabetes, secondary hypogonadism, and hypothyroidism, cause restrictive or dilated cardiomyopathy with conduction abnormalities, and increased risk for dysteria, vibrio, and Yersinia infections. There's also a discussion of what causes hypogonadism. This is important. Could be primary, like testicular issues, usually congenital, like Klinefelter or cryptorchidism, or drugs like ketoconazole, alkylating agent, or orchitis like mumps, trauma, or torsion, and chronic kidney disease. and could be secondary like pituitary or hypothalamic. Okay, could be gonadotroph damage if there's a tumor, cranial trauma, infiltrating diseases, hemochromatosis, apoplexy, you know. And there is another thing, gonadotropin suppression, like if there's exogenous androgen, hyperprolactinemia, diabetes mellitus, morbid obesity. Okay, these are secondary causes of hypogonadism. And there is combined, like primary and secondary, like if there is hypercortisolism or cirrhosis, can cause this type of hypogonadism. Okay, now somebody like 75 have DEXA scan T-score minus 2.5 or fracture. Okay, and then you do lab, creatine is like 2.3. So there's osteoporosis and CKD. How do you treat it? How do you treat osteoporosis in someone with chronic kidney disease? Do you give bisphosphonate, aldronate? No. You give denosumab. Okay, this is an important thing to know. How do you manage osteoporosis and CKD? That brings us, what are the options to manage osteoporosis? So there are 6 treatment options. Number 1, you do calcium and vitamin D. This is for any postmenopausal woman. Okay, and then you along with daily dietary and supplemental should be around 1200 milligram of calcium and 800 units of vitamin D daily. Okay, so other is oral bisphosphonate, oral IV bisphosphonate. This is the go-to. You avoid in somebody who has esophagitis. Okay, must be taking like on empty stomach 1 hour before food or other medications, and you have to sit upright for 1 hour, and not recommended if kidney disease like creatinine clearance less than 30, and cause atypical bone infection may occur with the prolonged use as well. So if they have kidney disease or esophagitis, you do denosumab. Okay, there is risk of infection with that drug as well, but it can be used in renal insufficiency and monitor for hypocalcemia. Other options like teriparatide, which is recombinant human parathyroid hormone analog. It's like parathyroid hormone. This one, if someone cannot tolerate bisphosphonate, you can do that. But you monitor calcium, uric acid, and renal function with that. Other option, nasal calcitonin, reduce risk of fracture, and shown improvement only for vertebral fracture. Okay, so it's not the first line. If there's vertebral fracture, that's what you give. Last options are raloxifene, which is selective estrogen receptor modulator for postmenopausal patient that does not tolerate bisphosphonate. You can do that, okay? But there is a risk for increased risk of thrombosis and also protect against vertebral fracture only as well, okay? Okay. Now you have 62-year-old. She had hysterectomy, okay? And then she stopped taking estrogen. Okay, hysterectomy. Stopped estrogen. And she take levothyroxine for hypothyroidism. So you do TSH is 0.03. Free T4 is 2.7. So this is why she's having thyrotoxicosis. Why she has thyrotoxicosis. And this one, this is iatrogenic thyrotoxicosis. There's factitious when the lady taking thyroid to lose weight. This one iatrogenic because she stopped taking estrogen because of side effects. But if you take an estrogen, this is going to increase the protein that binds to the thyroid, so you need higher dose. So if you stop estrogen, you need to lower the thyroid dose. Okay. So that brings us to the discussion. What are the interaction? How does other drugs interact with levothyroxine? Okay, there are some drugs that decrease absorption. Some work with the thyroid binding globulin, either increase or decrease concentration. Some increase thyroid metabolism. Okay. So there are different drugs. The one that decreases thyroid absorption, we have cholestyramine, iron, calcium, aluminium, PPI, and sacralfate. Okay, these decrease thyroid absorption. And we have one that increased thyroid binding globulin concentration, like estrogen, tamoxifen, raloxifene, heroin, and methadone. And there are one that decreases thyroid globulin binding globulin concentration, like androgen, steroid, anabolic steroid, and slow release nicotinic acid as well. And there are the ones that increase thyroid hormone metabolism, like rifampin, phenytoin, and carbamazepine. Okay. Okay, this case is very important, interesting case. So you see 62-year-old man comes in with fatigue and lethargy, constipation, cold intolerance, okay? You see low blood pressure as well, low potassium, okay? Low potassium sodium, okay? And then you check the TSH low, 0.4. Low free T4 as well, like 0.6, okay? T3 maybe a little bit elevated, 88, not too high, also as well low. So what do you do next step? Do you start thyroid therapy, or do you check for adrenal insufficiency? You check for adrenal insufficiency. You want to do synthropine stimulation test, because there could be adrenal insufficiency, and if you treat thyroid, this is very tricky. If you treat hypothyroidism, you just give thyroid, you're going to worsen the adrenal insufficiency, and the patient could go into crisis and die. Okay? So what other things can cause low TSH and low free T4? Okay? Number one could be central hypothyroidism. If there is like, it's like from the pituitary, it's not reducing, no TSH, no T3, no T4, nothing, from the father. Others are subclinical thyrotoxicosis, okay? Could be low TSH and initially low free T4, especially those in someone taking T3 thyroid supplement and toxic multinodular goiter, okay? So you need to do radioiodine uptake to diagnose what's going on. And there is euthyroid sickness syndrome, like sick people have low TSH, low free T4, but reverse T3 would be high, okay? Normal TSH response to TRH. You don't treat anything, just watch them. Could be medications as well. Medication could suppress TSH and causes low to normal T4, like dopamine, steroid, and octreotide. Can cause like similar to hypopituitary, like central hypothyroidism. Suppresses the father. Now, you see somebody who's 35-year-old woman having hypothyroidism. So she is on T3 therapy. So you just like routine, you check the labs. Okay, TSH 1.4. Okay, free T4 is like 2.6. And T3 is like 65. Okay. What's best next step? What do you do in this situation? Do you increase the T4 is a little bit elevated, TSH is normal. So do you increase or decrease thyroid, or just continue same? This one continue the same. Our goal is TSH, that's what we look for. If it's within normal, that's fine. So how do you evaluate levothyroxine replacement therapy? Okay, levothyroxine replacement therapy is very important. Initial dose, you do low dose, like someone who's elderly, heart disease, you do 25 to 50 microgram daily. But in young healthy adult, you just do full replacement dose, which is 75 to 125 microgram daily. You start low and increase, okay, every 6 weeks until TSH within normal limit. How often do you check TSH? You check TSH every 6 to 12 months after that, okay. So what conditions require higher doses of levothyroxine? Like if you have celiac disease, a drug that interfere with absorption like iron, calcium, need higher thyroid. A drug that increase thyroxine metabolism like phenytoin, carbamazepine, and rifampin need higher dose of thyroid. Obesity, pregnancy, there are increased estrogen, so increases the thyroid binding globulin, so you need higher thyroid. And overt proteinuria can need more thyroid. because some of it, I guess it goes away with the urine, with the proteinuria. So now let's review what we talked about. We talked about therapy for thyroid replacement, consentropine to rule out adrenal crisis, iatrogenic thyrotoxicosis, denosumab for osteoporosis, talked about hemochromatosis, causes hypogonadism along with opioid as well. Low LH if you take anabolic steroid. Adrenal venous sampling can be helpful diagnosing adrenal adenoma, IGF if you are suspecting chronic acromegaly. CKD if somebody could cause low libido, it causes hypogonadism. And that concludes our discussion for this session. Thank you for listening.